Hi everyone, thanks for listening to my presentations. Today I'll be talking about hepatitis B virus infection treatment. Other topics on hepatitis B virus that are relevant have been published here, such as diagnosis, risk factors, symptoms, and so on. You can check my channel for that. In acute hepatitis B viral infection, we will quickly assay for hepatitis B surface antigen and IgM with anti-hepatitis B C, which means antibody to hepatitis B core antigen. And with that, we'll be able to make the determination whether this is an acute infection or not. If it is determined that this individual is not immune, which means no immunity, or we are not sure, then we should embark on hepatitis B immunoglobulin with hepatitis B vaccine. We should administer both. And we will administer both to all sexual contacts. And also in case of needle prick, a nurse in the hospital, or sexual attack, sexual assault, or a child delivered to a mother that is hepatitis B positive. Don't worry, I will go into all that later on. Generally, or let me simply say in most cases, all we do is supportive treatment, giving generous fluid or IV fluid, good diet, symptomatic treatment of the symptom or symptoms. Like in case of pain, we give analgesics. In case of fever, we give antipyretics. And individual vomiting will be given antiemetics. We can have blood transfusion or blood product transfusion depending on what is required at that moment. Antibiotics will be very useful in the face of secondary bacterial infection within the system of the affected individual. We will do more than general supportive treatment if we are dealing with certain situations like severe cases of hepatitis B virus infection, long-standing cases, coagulopathy are setting right now, or we're dealing with a very high bilirubin level, or this is acute liver failure. We will do more than just general supportive measures. Or this person is even immunocompromised or on immunosuppressive medications. We have to do more. If there is co-infection with hepatitis C or co-infection with HIV or concomitant liver disease, or this is an elderly, we have to do more than general support. In that case, if we have to do more, then we have to make selection of antiviral agent. We can go for Tenofovir or Entecavir, Lamivudine or Telbivudine. At this stage, we have to avoid the use of interferon. It will be useful later on, and I'll get to that in a bit. We have to regularly monitor, for hepatitis B surface antigen at 4 weeks apart, at least twice. Then we can stop treatment after we are no longer getting hepatitis B surface antigen. That is, when the patient becomes hepatitis B surface antigen negative, we can stop treatment. But we have to assay for that hepatitis B surface antigen at least 2 tests within 4 weeks apart. In chronic hepatitis B, we'll be dealing with persistent hepatitis B surface antigen that is greater than 6 months, presence of liver inflammation, presence of liver cirrhosis, We also know the status of hepatitis B envelope antigen, the viral load, and of course the genotype. In chronic hepatitis B virus infection, we have to take thorough history. Particularly, we want to know if this individual is greater than 40 years old, or if this individual has family history of hepatocellular carcinoma. And after that, we have to embark on a thorough physical examination. We'll head to the lab. And what are we doing there? We want to know whether there is replication going on right now. Viral replication, particularly in hepatitis B, will show with the value of hepatitis B envelope antigen, antibodies to hepatitis B envelope, and of course hepatitis B virus DNA. Secondly, we want to find out whether or not we are dealing with other viruses at the same time that we are dealing with hepatitis B virus. In other words, is there any co-infection somewhere, particularly in IV drug users? So we want to determine the antibody to hepatitis C virus, to hepatitis D virus, and of course to human immunodeficiency virus. Thirdly, we will carry out some other tests like complete blood count, platelet count, INR, liver enzymes, albumin, and bilirubin. In other words, complete blood count with liver function test and liver enzymes. In chronic hepatitis B virus infection, we have to screen for liver fibrosis. And we can do that through vibration controlled transient elastography, serum fibrosis panel, or liver biopsy. Here, liver biopsy will be the gold standard when it comes to liver fibrosis. And we will do that if we are suspicious of fibrosis or there is increased ALT, but hepatitis B virus DNA is low, or we are dealing with persistently increased viral load, but ALT is less than twice the upper limit of the normal, or we are dealing with somebody greater than 40 years old, or an individual with positive family history of hepatocellular carcinoma. So in all these situations, we have to screen for liver fibrosis using liver biopsy, which is the gold standard, or vibration controlled transient elastography, or serum fibrosis panel. We have to treat immediately in chronic hepatitis B virus infection if there is severe hepatitis with jaundice and there is hepatic decompensation. In chronic hepatitis B virus infection, if we have made the determination that we will not treat, either because there's no hepatic decompensation, or there's no massive jaundice, or the situation is not that bad, then we have to assay for the level of hepatitis B envelope antigen. Okay? If the patient is hepatitis B envelope antigen positive and hepatitis B virus DNA is greater than 20,000 international units per ml, and with ALT but no cirrhosis, then we must do ALT every 3 to 6 months and hepatitis B envelope antigen every 6 to 12 months. Remember, this will be for signs of viral replication. That is, hepatitis B envelope antigen, hepatitis B virus DNA, and then anti-hepatitis B envelope will all be pointing to viral replication. But ALT will be telling us the extent of the liver injury. Okay, if there is a rise in ALT, telling us there is more liver injury at about 1 to twice the upper limit of normal, then we have to recheck at every 1 to 3 months. I mean, we have to recheck the value of ALT every month or every 3 months. And then recheck the value of hepatitis B envelope antigen every 6 months. And then we can do that with liver biopsy. But if ALT is greater than twice the upper limit for about 3 to 6 months, with positive hepatitis B envelope antigen and hepatitis B virus DNA is greater than 20,000 international units per ml, we have to treat, telling us there is massive liver injury or liver damage that is ongoing and telling us there is viral replication. Then we have to act quickly. We have to treat and treat right now. If you think that you are not going to treat this patient, but the result of hepatitis B envelope antigen is negative, hepatitis B virus DNA is less than 2,000 international units per ml, and ALT is normal without liver cirrhosis, then we'll do something. Then we have to be checking the level of ALT and hepatitis B virus DNA every 3 months for 1 year. If we are getting the value to be within the normal range, then we reduce the frequency of testing to every 6 months to every 12 months. If ALT is increasing at 1 to 2 of the upper limit, then we have to monitor ALT and hepatitis B virus DNA every 3 months. And we will do liver biopsy if we are persistently getting increased ALT level. If fibrosis has occurred, then we must treat. If hepatitis B virus DNA is increasing to 20,000 international units per ml, we must treat. Or if ALT is rising to twice the upper limit, then we must treat. And of course, we'll have ultrasound to rule out hepatocellular carcinoma at this time. The initial treatment here, if we are dealing with fibrosis with worsening level of markers like ALT, hepatitis B virus DNA, and hepatitis B envelope antigen, is PEG interferon. That is Pegylated Interferon Alpha. We can also use Tenofovir alafenamide, Tenofovir disoproxil fumarate, and Entecavir. So the other time when I was talking about acute hepatitis B virus infection, I said PEG interferon should be avoided that time. Now we need PEG interferon. For how long are we going to place this individual on Pegylated Interferon Alpha? For 1 year. The rest of the 3 medications, that is Tenofovir alafenamide, Tenofovir disoproxil fumarate, and Entecavir, will be for indefinite period of time. So PEG interferon could not be used indefinitely. You can check my channel for full presentation on PEG interferon alpha 2A. I've made that publication already. You'll see that it was necessary for me then to have published the info on PEG interferon because we now need it. Someone should ask me, is it possible to stop treatment when you are dealing with chronic hepatitis B virus? And if that is the case, when can you stop treatment? Here is the answer. We will stop treatment when hepatitis B surface antigen is no longer appearing. And that must be when we have carried out the test 2 times, at least in 4 weeks apart. So only 2 tests in 8 weeks. We can still observe that is, we will not treat if there is liver compensation. So we can observe for 3 to 6 months if there's liver compensation, because that's what we want. What we hate is decompensation. So if there's compensation, observe for 3 to 6 months. But treat if there is no loss of hepatitis B envelope antigen. In other words, you are telling us that there is no decompensation, but when we assay for the parameters that will show us whether there is viral replication or not, hepatitis B envelope antigen is still positive. Then we have to treat. We will stop the treatment here with compensated liver, and now hepatitis B envelope antigen is being seroconverted to anti-hepatitis B envelope. When we find that, we will stop treatment. In liver cirrhosis, we will do certain things differently. We will assay using polymerase chain reaction for hepatitis B virus DNA and ALT. If not decompensating, which is what we want, right? Which means there's compensation. Okay, we will use other medications apart from peg interferon, and we will use those medications indefinitely. Remember Tenofovir and Entecavir, okay? If there is decompensation, we have to treat immediately without considering the value of ALT or hepatitis B virus DNA. And we will at the same time be monitoring for any renal damage using renal function test, and also have referral for liver transplant. If this patient is on immunosuppressants, we have to give antiviral agent first. Why that? Because the immunosuppressant medications can reactivate hepatitis B virus infection. To prevent vertical transmission from mother to the unborn child, we have to give antiviral agents in 3rd trimester, regardless of the level of ALT. But once the infection is diagnosed, once hepatitis B virus infection has been diagnosed, we'll give the antiviral agent in 3rd trimester. Remember, no interferon in any pregnant woman. So in pregnancy, keep interferon off the table. In hepatocellular carcinoma, we have to give antiviral agents. In concomitant hepatitis C virus infection, we have to initiate treatment at the same time that the patient starts hepatitis C virus treatment. Interferon is contraindicated in pregnant women, like I've just said about 1 minute ago, right? It's contraindicated in decompensated disease, and also contraindicated in compensated cirrhosis with portal hypertension. Interferon is better for young patients with compensated liver disease. It's also better for patients not wanting long-term therapy. Also good in phase of hepatitis B virus genotype A and few cases of genotype B. When there's low hepatitis B virus DNA, interferon is fine. And in the face of high ALT, you can make use of interferon, that'll be good. Use only subcutaneous at the rate of 180 micrograms every week for 48 weeks. And with that, I've come to the end of the treatment of hepatitis B virus, both the acute and chronic hepatitis B virus infection. Thanks for listening to my presentations. Remember to share, remember to subscribe. I appreciate it.